Hello, seniors. I am Dr. Robert Harrison. According to the American Heart Association, nearly half of all American adults, about 122 million people, have high blood pressure. And here's the shocking part: 75% of them are on medication to control it. But medication isn't controlling the disease. Every year, over 675,000 Americans die from hypertension-related complications despite taking their pills faithfully. I'm Dr. Michael Kent, and after more than 20 years performing cardiac surgery, I can tell you exactly why these medications fail. Because what you've been told about high blood pressure is fundamentally incomplete. You've been told that hypertension is a plumbing issue. Too much fluid volume in your circulatory system. Your physician tells you to cut back on sodium, take a diuretic to remove excess water. The fluid volume decreases, your pressure readings drop. Problem solved, except the problem isn't solved at all. That entire framework is outdated medical thinking from 50 years ago. It's incomplete, misleading, and keeping millions of people sick despite having controlled numbers on their monitors. The reality is far more complex. Hypertension isn't a plumbing problem about fluid volume. It's about the pipes themselves. Your arteries aren't simply overfilled. They're damaged, deteriorating, rigid. They've undergone structural changes at the cellular level that no prescription medication can repair. When I perform bypass surgery and open someone's chest, I can see this damage immediately. A healthy artery has elasticity. It springs back when you make an incision. But a diseased artery from someone with chronic hypertension feels like cutting into bone. It's stiff, calcified, rigid. That rigidity is what hypertension actually represents. And medications don't fix rigidity. They manipulate the pressure reading on your monitor, but don't repair underlying structural damage. By the end of this video, you'll understand the 4 hidden mechanisms that create hypertension and the complete 4-step protocol to actually reverse this damage at the structural level. This is cellular biology and biochemistry. Let's start by understanding what hypertension actually is at the cellular level. Your arteries are extraordinarily complex living structures composed of 3 distinct layers. The innermost layer, the surface that directly contacts your flowing blood, is called the endothelium. It's a single layer of cells thinner than tissue paper that lines every blood vessel throughout your body. This layer is absolutely critical. It's not merely a physical barrier, but an active metabolic organ producing chemical signals that control blood flow, prevent inappropriate clotting, regulate inflammation, and maintain vessel health. The endothelium itself has a protective coating, a microscopic layer called the glycolyx. Think of it like a non-stick coating on the interior surface of your arteries. This coating is constructed from sugar molecules and proteins only a few micrometers thick, invisible to the naked eye, but one of the most important structures in your cardiovascular system. Research published in Pfluger's archive in 2007 established that the glycolyx performs several critical functions. First, it creates a smooth, frictionless surface, allowing blood to flow without resistance. Second, it prevents inflammatory molecules from reaching and attaching to the vessel wall. Third, it senses changes in blood flow and signals the endothelium to release nitric oxide, a gas molecule that keeps vessels relaxed and dilated. When your glycolyx remains intact and healthy, your vessels stay flexible and functional. But when it becomes damaged and breaks down, everything falls apart. Elevated blood sugar levels, chronic systemic inflammation, cigarette smoking, and oxidative stress strip away the glycolyx like acid dissolving a protective coating. Once it's gone, your vessel wall becomes exposed and vulnerable. Inflammatory molecules from your bloodstream attach to the endothelium. White blood cells adhere to the wall. LDL cholesterol particles penetrate into vessel tissue. Atherosclerotic plaque begins forming. The endothelium stops producing adequate nitric oxide. Your vessels constrict and lose flexibility. Blood pressure climbs. This is the first mechanism of hypertension: glycolyx destruction and endothelial damage. Here's the critical point: no blood pressure medication repairs the glycolyx. ACE inhibitors don't repair it. Beta blockers don't repair it. Calcium channel blockers don't repair it. Diuretics certainly don't repair it. They manage the pressure reading on your monitor, but the underlying damage remains untreated. So your blood pressure numbers might look controlled on medication, but your vessels are still damaged, still vulnerable, still progressing silently toward a stroke or heart attack. This explains why people on blood pressure medication still experience cardiovascular events. The medication treats the symptom, but not the cause. This brings us to the second mechanism, arterial stiffness and calcification. Most physicians completely overlook this. They focus exclusively on blood pressure numbers, but ignore whether arteries are stiff or flexible. And that distinction matters more than the numbers themselves. Research published in the Journal of the American College of Cardiology in 2010 demonstrated through systematic review and meta-analysis that arterial stiffness predicts cardiovascular events and all-cause mortality better than traditional blood pressure measurements alone. Blood pressure is measured as two numbers, systolic over diastolic. The difference between them, called pulse pressure, gives information about arterial stiffness. Normal pulse pressure falls between 40 and 50. But as arteries stiffen with aging and disease, systolic pressure increases while diastolic pressure decreases. You might end up with blood pressure of 162 over 72. The systolic is elevated, the diastolic is low, but the pulse pressure is 90. This wide pulse pressure, anything over 65, indicates that arteries are stiff and calcified. Your aorta has lost its elasticity and shock-absorbing capacity. A 2006 expert consensus document published in the European Heart Journal established that arterial stiffness can be measured directly using a test called pulse wave velocity. This measures how rapidly a pressure wave travels through your arterial system. In flexible, healthy arteries, the wave travels slowly around 6 to 7 ms. In stiff, diseased arteries, the wave travels rapidly, 12 to 15 meters/s. The faster the wave velocity, the stiffer your arteries, the higher your cardiovascular risk. This test is readily available and non-invasive, taking about 10 minutes to perform, but almost no physicians order it routinely. Why not? Because there's no prescription medication that fixes arterial stiffness directly. Research published in the American Journal of Hypertension in 2004 explained the implications of vascular stiffening for systolic blood pressure, noting that current pharmaceutical approaches don't address the underlying structural problem. Let me explain what causes arterial stiffness at the tissue level. Your artery wall consists of three distinct layers. The middle layer, called the tunica media, is composed of smooth muscle cells and elastic fibers. This middle layer gives your arteries their flexibility and ability to expand and contract. But as you age, especially with hypertension, diabetes, or chronic inflammation, several destructive processes affect this middle layer. First, calcium deposits begin forming. Calcium belongs in your skeletal system, not arterial walls. But when vessels are chronically inflamed, calcium migrates from your bloodstream into the tunica media. It crystallizes and forms deposits, making the vessel wall progressively more rigid. Second, elastic fibers break down and degrade, gradually replaced by collagen, which is stiff and inflexible. Third, smooth muscle cells undergo a pathological transformation, stop functioning like muscle cells, and start behaving like bone-forming cells, actively depositing calcium and promoting calcification of the vessel wall. A comprehensive review published in the Journal of the American College of Cardiology in 2019 established that this process, called vascular calcification, is the primary driver of arterial stiffness and significantly increases cardiovascular risk. By the time someone reaches 65 with poorly controlled hypertension for years, their arteries can resemble bone tissue more than blood vessels. They're calcified, rigid, and inflexible, and no blood pressure medication reverses this process. ACE inhibitors don't remove calcium deposits from vessel walls. Calcium channel blockers block calcium from entering smooth muscle cells, which helps them relax acutely, but they don't remove calcium already embedded in the structural wall. The calcification remains, the stiffness persists. So here's the crucial question. Can you actually reverse arterial calcification? The answer is yes, but not with prescription medications with specific nutritional interventions that most physicians have never learned about. The third mechanism is nitric oxide deficiency. Nitric oxide is a gas molecule produced by your endothelial cells. Research published in the European Heart Journal in 2012 established that nitric oxide is one of the most important signaling molecules in your cardiovascular system. When nitric oxide is released from the endothelium, it diffuses into the smooth muscle layer of your vessel walls, signaling muscle cells to relax, your vessels dilate, blood flows more easily, resistance drops, blood pressure decreases. Healthy functional endothelium produces nitric oxide continuously, keeping vessels in a relaxed state and maintaining normal blood pressure. But when your endothelium becomes damaged, when the glycolyx is stripped away, nitric oxide production drops dramatically. Your vessels can't relax properly, they remain constricted. Blood pressure rises and stays elevated. The enzyme responsible for producing nitric oxide is called endothelial nitric oxide synthase, or eNOS. This enzyme is damaged by the exact same factors that damage the glycolyx: elevated blood sugar, oxidative stress, chronic inflammation. The eNOS enzyme requires several coactors to function properly. The most critical is a molecule called tetrahydrobiopterin, or BH4. When BH4 levels are adequate, eNOS produces nitric oxide efficiently. When BH4 becomes depleted, eNOS becomes dysfunctional, producing harmful free radicals instead of beneficial nitric oxide. The enzyme is also activated by shear stress, the mechanical friction of blood flowing across the endothelial surface. When blood flow increases, the friction activates eNOS. This is one reason why exercise lowers blood pressure. A 2014 meta-analysis published in Sports Medicine examined the role of isometric exercise training in reducing blood pressure and identified potential mechanisms. The research found that isometric resistance training, which involves contracting muscles without movement, is particularly effective. The specific protocol studied involves squeezing a hand grip device at 30% of maximum strength for 2 minutes, resting for 1 minute, then repeating 4 times. This exact protocol has been demonstrated in multiple clinical studies to lower blood pressure by 8 to 12 points systolic after 8 weeks of consistent practice. Now, the fourth and final mechanism, the insulin-kidney connection. This explains why reducing sodium intake doesn't work for most people with hypertension. Your kidneys control blood pressure by regulating sodium balance, but this system depends entirely on your kidneys being able to respond appropriately to sodium intake. Here's the critical problem. Insulin blocks sodium excretion from the kidneys. When insulin levels are chronically elevated, your kidneys retain sodium regardless of how much you're consuming. Research published in the New England Journal of Medicine in 1987 established that insulin resistance is present in essential hypertension and plays a causal role in blood pressure elevation. Insulin acts on the kidneys through several pathways. First, it directly stimulates sodium reabsorption in the proximal tubule of the nephron. More reabsorption means less sodium excreted in urine and more retained in your bloodstream. Second, insulin activates the sympathetic nervous system, causing your kidneys to release rain, which triggers a hormonal cascade, resulting in aldosterone release. Aldosterone instructs your kidneys to retain sodium and excrete potassium. Third, insulin increases the sensitivity of your blood vessels to angiotensin II, a powerful vasoconstrictor. A landmark 1991 paper published in Diabetes Care established that insulin resistance is a multi-ascended syndrome responsible for hypertension, obesity, dyslipidemia, and atherosclerotic cardiovascular disease. This is why people with insulin resistance, prediabetes, or type 2 diabetes almost invariably develop hypertension. The elevated insulin is locking their kidneys in continuous retention mode. And here's what most people don't realize. You can have significant insulin resistance without having diabetes. Your fasting blood glucose might be completely normal. Your hemoglobin A1C might be normal, but your insulin levels could be substantially elevated, and that elevated insulin is driving your hypertension silently. Most physicians never check insulin levels. They check glucose and A1C. If those are normal, they assume insulin is fine. They're wrong. Now, let me give you the complete 4-step protocol to reverse these mechanisms. The first step is restoring the glycolyx. First, you must stop destroying it. The primary destroyers are elevated blood sugar and oxidative stress. Every time your blood sugar spikes above 145, it damages the glycolyx through a process called glycation. So, step 1 is stabilizing your blood sugar. Not just avoiding diabetes, but keeping your post-meal blood sugar below 140 consistently. For most people, this means reducing refined carbohydrates significantly. Not eliminating all carbohydrates, but choosing carbohydrates that don't spike blood sugar dramatically. Whole foods, non-starchy vegetables, legumes, some fruits, avoiding sugar, white bread, white rice, pasta, and baked goods. Second, you must provide the building blocks your body needs to rebuild the glycoalix. The glycoalix is constructed primarily from molecules called glycosaminoglycans, long chains of sulfated sugar molecules. The best dietary sources are sulfated polysaccharides from seaweed, specifically fucoidin from brown seaweed. Research has shown these compounds restore glycoalix thickness and improve endothelial function. Supplements containing fucoidin are available. Studies demonstrating benefit use doses of 600 to 1,000 milligrams daily. Third, you need to reduce oxidative stress significantly. The most potent antioxidants for vascular health are polyphenols from colorful vegetables and fruits, berries, dark leafy greens, beets, dark chocolate, green tea. These foods contain compounds that neutralize free radicals before they can damage your glycoalix. Picture a 71-year-old with hypertension for 13 years, taking 2 medications. Blood pressure controlled at 130/82. But lab tests showed elevated markers of endothelial dysfunction. Started on a protocol, eliminated all refined carbohydrates, added fucoidin supplement at 800 milligrams daily, dramatically increased polyphenol-rich foods with a cup of mixed berries and 2 cups of leafy greens daily. After 12 weeks, endothelial function tests showed dilation improved from 5% to 13%. Blood pressure dropped from 130/82 to 116/74. Reduced one medication after 6 months off both medications entirely. Blood pressure stable at 120/76. Now step 2, decalcification, removing calcium from your artery walls and restoring flexibility. Most people assume that once calcium deposits in arteries, it's permanent and irreversible. They're mistaken. The key protein is called matrix glow protein, or MGP. This protein functions like a traffic controller for calcium. When MGP is properly activated, it directs calcium into your bones where it belongs. When MGP is not activated, calcium migrates into your arteries and deposits in vessel walls. MGP is activated by vitamin K2, specifically the MK7 form. Research published in Atherosclerosis in 2009 found that high dietary mequinone intake is associated with reduced coronary calcification. The Rotterdam study published in the Journal of Nutrition in 2004 established that dietary intake of menaquinone is associated with reduced risk of coronary heart disease. Without adequate vitamin K2, MGP remains inactive. Calcium deposits freely in your arteries. With adequate vitamin K2, MGP becomes activated, redirecting calcium out of your arteries and into your bones. This process can actually reverse arterial calcification. Studies showing benefit use doses of 180 to 360 micrograms daily of MK7. But vitamin K2 is only part of the solution. Calcium needs vitamin D to effectively enter bone tissue. Vitamin D increases calcium absorption from your digestive tract and helps incorporate calcium into bone matrix. So you need both working together. The third component is magnesium. Magnesium is nature's natural calcium channel blocker. When magnesium levels are adequate, it blocks calcium from entering smooth muscle cells and vessel walls inappropriately. When magnesium is deficient, calcium floods into smooth muscle cells. Vessels constrict. Blood pressure rises. Magnesium also prevents calcium from crystallizing and forming deposits in vessel walls. Most people are deficient in magnesium because it's found primarily in dark leafy greens, nuts, seeds, and whole grains. Several factors actively deplete magnesium: chronic stress, alcohol consumption, diuretic medications, proton pump inhibitors used for reflux. The solution is magnesium supplementation with highly absorbable forms like magnesium glycinate or magnesium threonate. These forms are efficiently absorbed. The dose for cardiovascular health is 400 to 600 milligrams daily. Picture a 74-year-old with hypertension for 18 years taking 4 medications. Blood pressure barely controlled at 136/86. CT scan showed severe calcification throughout aorta. Started on decalcification protocol. Vitamin K2 at 360 micrograms daily. Vitamin D at 6,000 international units daily. Magnesium glycinate at 600 mg daily. After 6 months, CT scan showed calcification score decreased by 9%. Blood pressure dropped to 122/78, reduced from 4 medications to 3. After 1 year, calcium score decreased by 16%. After 18 months on 1 medication with excellent control. Now step 3, nitric oxide restoration. First, protect and boost BH4, the critical coactor for the eNOS enzyme. Ensure adequate intake of folate, vitamin C, and vitamin E. These vitamins help regenerate BH4 and prevent eNOS uncoupling. Folate from dark leafy greens, vitamin C from citrus fruits, berries, and bell peppers. Vitamin E from nuts and seeds. Research published in the Journal of Cardiovascular Pharmacology in 1999 demonstrated that oral vitamin C reduces arterial stiffness in humans. Second, stimulate eNOS through shear stress. The most effective method is isometric hand grip training. Squeeze a hand grip device at 30% of maximum strength for 2 minutes. Rest 1 minute. Repeat 4 times. Do this 4 times per week. Third, practice nasal breathing. When you breathe through your nose instead of your mouth, your nasal passages produce nitric oxide. Studies have demonstrated that nasal breathing increases blood nitric oxide levels by up to 400% compared to mouth breathing. Now, step 4, the insulin reset. This unlocks your kidneys and allows them to excrete sodium appropriately. Elevated insulin locks your kidneys in sodium retention mode. You must lower insulin levels. The most effective method is time-restricted eating. This means condensing all your food intake into a specific window each day and fasting the remaining hours. For people with hypertension, I recommend a 16-hour fast with an 8-hour eating window. Consume all meals between noon and 8 p.m. Fast from 8 p.m. until noon the next day. During the fasting window, drink water, black coffee, or plain tea, no calories. Research demonstrates that time-restricted eating lowers blood pressure by 9 to 11 points systolic within 8 weeks without any change in what you eat. Just when you eat, the mechanism is purely insulin-related. Lower insulin means unlocked kidneys, which means appropriate sodium excretion, which means normalized blood pressure. You must also reduce insulin resistance at the cellular level. The most effective way to improve insulin sensitivity is resistance training. When you perform resistance exercises, your muscles develop more insulin receptors. Studies show that resistance training 2 to 3 times weekly lowers fasting insulin by 20 to 30% within 12 weeks. This is what genuinely reversing hypertension looks like. Not managing symptoms temporarily, not controlling numbers with pills, but fixing the underlying mechanisms permanently. Glycolysis restoration, arterial decalcification, nitric oxide production, insulin normalization. These 4 steps address the actual root causes of hypertension. When you address root causes, blood pressure normalizes naturally. Your body heals itself when you provide the right conditions. Start with 1 step. Pick the step that resonates most with you. If you eat refined carbohydrates and sugary foods, start with glycolysis restoration by stabilizing blood sugar. If you're overweight or have signs of insulin resistance, start with the insulin reset through time-restricted eating. If you rarely exercise, start with nitric oxide restoration through isometric training. I'm not telling you to stop your blood pressure medication abruptly. That would be dangerous. Medication manages symptoms while these protocols fix root causes. You need both initially. Start implementing these protocols while continuing your current medication. As your blood pressure improves over weeks and months, work collaboratively with your physician to reduce medication gradually under supervision. Monitor your blood pressure daily at home. Track the trends. When your numbers consistently improve and remain stable, discuss medication reduction with your doctor. Never stop medication suddenly on your own. Never reduce doses without medical supervision. But also don't accept the belief that you'll need medication for life. Conventional medicine doesn't know how to reverse vascular damage. They only know how to temporarily manage pressure readings. But you now know differently. You understand the glycolysis, arterial calcification, nitric oxide, and the insulin-kidney connection. You understand the mechanisms. And when you understand mechanisms, you can correct them. This is what separates managing from reversing. Managing is pills for life. Reversing is structural repair at the cellular level. These 4 mechanisms create hypertension. and standard medical care doesn't address any of them effectively. Pills manipulate pressure temporarily without repairing underlying damage, but you can repair that damage. Glycoalix restoration with blood sugar control, sulfated polysaccharides, and antioxidants. Decalcification with vitamin K2, vitamin D, and magnesium. Nitric oxide restoration with shear, stress, exercise, and nasal breathing. Insulin reset with time-restricted eating and resistance training. When you reverse the mechanisms, blood pressure normalizes, not because you're artificially forcing it down with medication, but because you've repaired your vascular system at the fundamental level. You have this information now, information that most physicians don't have or don't think about. Information that could free you from medication and prevent becoming one of the 675,000 Americans who die from hypertension complications each year. Use it. Implement it. Start today. Subscribe to this channel. I'm committed to sharing surgical knowledge and insights that could keep you out of my operating room. Take care of your vessels. They're the only ones you'll ever have. Hypertension isn't a permanent life sentence. It's a reversible condition if you're willing to understand the mechanisms and do the work to correct them. The choice is entirely yours. Choose reversal over management.